First, thanks to the Scientific Program Committee of EBNT for inviting me to this keynote lecture. My talk will be based on how the transplant is evolving in newly diagnosed multiple myeloma patients. This slide, you can see my disclosures. And when we evaluate how the treatment of patients with multiple myeloma evolved over the years, maybe you know that melphalan was the first agent utilized for the treatment of patients with multiple myeloma. And this occurred more than 40 years ago. The first attempt in order to improve the treatment of patients with multiple myeloma was to introduce the conventional chemotherapy. But a large meta-analysis was conducted in order to evaluate if the conventional chemotherapy would be better than melphalan and prednisone. And in this large meta-analysis, we had the opportunity to see how the combination chemotherapy was not superior to the conventional melphalan and prednisone, and melphalan remained the mainstay for myeloma therapy for decades. The first innovation we've seen for the management of patients with multiple myeloma was actually the introduction of a high-dose chemotherapy, high-dose melphalan, followed by autologous stem cell transplantation. And in fact, there were 4 phase 3 randomized trials conducted in the 90s by different cooperative groups, the French group, the English group, the Spanish myeloma group, as well as the US group, to compare the conventional chemotherapy with autologous stem cell transplantation. In all of them, a significant benefit for autologous stem cell transplantation was observed in terms of event-free survival. However, it's true that in terms of overall survival, only 2 of these studies resulted into a significant benefit in terms of overall survival. But when the melphalan doses were evaluated across these different 4 studies, we had the opportunity to see how in the Spanish study as well as in the US study, patients actually received higher dose of melphalan in comparison with the French and the English study. And as based of these 4 phase 3 randomized studies, autologous stem cell transplantation remained as a standard approach that continue available today, more than 20 years later, for every newly diagnosed myeloma patient after induction. And today, the current guidelines includes the administration of maintenance after high-dose therapy followed by autologous stem cell transplantation. These are the outstanding questions we can plan today in 2020 for the management of newly diagnosed myeloma patients transplant eligible. The first one is which patients are transplant candidates, and in 2020, chronological age should not be anymore considered as the only factor to distinguish between transplant eligible and transplant ineligible patients. And we have to incorporate more and more the biological age, performance status, comorbidities, geriatric scales, considering at the end of the day that transplant is a procedure that can be available for many newly diagnosed myeloma patients, not only based on the chronological age. The second outstanding question today is what are the main objectives for newly diagnosed myeloma patients transplant eligible? And we know that the depth of the response is important. And in the past, we evaluated the response to the therapy according to conventional criteria, including serological complete response, meaning that the M component disappeared by both electrophoresis as well as immunofixation. Today, we are able to evaluate the response in more depth, and the concept of minimal residual disease has been introduced in the response criteria for the evaluation of the therapy in patients with multiple myeloma. And we know that the depth of the response, the longer the time to progression, as well as the longer the overall survival. Here you can see the experience of the Spanish myeloma group in a trial conducted in approximately 500 newly diagnosed myeloma patients receiving autologous stem cell transplantation. And when these patients achieved minimal residual disease negative, the outcome is significantly better, in this case in terms of progression-free survival, and utilizing next generation flow as a tool for the measurement of the minimal residual disease. But at the same time, the French group evaluated also a large series of newly diagnosed myeloma patients also treated with autologous stem cell transplantation and utilizing next generation sequencing instead of next generation flow, but the concept is the same. When patients achieved minimal residual disease negative, the outcome was significantly better. Today, in 2020, we evaluate the response inside of the bone marrow, but also outside of the bone marrow, utilizing imaging assessments like PET-CT. And in this slide, you can see the results of the Cassiopeia phase 3 study, in which minimal residual disease by next generation flow combined with PET-CT, and when patients achieved minimal residual disease negative in both inside and outside of the bone marrow, the progression-free survival was significantly better. So definitely the main objective for newly diagnosed myeloma patients today in 2020 should be to try as much as possible the patients to achieve minimal residual disease negative inside and outside of the bone marrow. As I previously said, the treatment for patients with multiple myeloma evolved, and over the last few years, many new agents incorporated to the treatment of these patients. Is transplant something complementary or alternative when we incorporate all these novel agents as part of the induction and even as part of the consolidation and maintenance therapy? This slide represents an integrated analysis of bortezomib, lenalidomide, and dexamethasone versus bortezomib, thalidomide, and dexamethasone in this population. Both studies were conducted by the Spanish myeloma group, but the main concept is how autologous stem cell transplantation upgrade the quality of the response after both VTD and VRD, in terms of VGPR rate or better, but also in terms of minimal residual disease negativity, indicating that a transplant is a complementary strategy rather than alternative, even using bortezomib, lenalidomide, and dexamethasone, or bortezomib, thalidomide, and dexamethasone. But you probably know how the monoclonal antibodies incorporated also to the treatment of patients with multiple myeloma, and the Cassiopeia phase 3 study put in context how daratumumab added to BTD resulted in a better progression-free survival in comparison with BTD alone. So if we incorporate the monoclonal antibody as part of the induction and consolidation, what is the role of autologous stem cell transplantation? And here you can see again how response rate deepened over time, and autologous stem cell transplantation as well as consolidation improved the quality of the response, even when we decided to utilize bortezomib, thalidomide, and dexamethasone, plus the monoclonal antibody anti-CD38, daratumumab in this case. So the answer to this question is definitely autologous stem cell transplantation is complementary after novel agents-based combination, and even after 3-drug-based combination plus monoclonal antibodies. Is it possible to proceed with tandem autologous stem cell transplantation in any subgroup of patients today in 2020? The answer is yes. This is a clinical trial conducted by the European Myeloma Network, in which after induction with bortezomib, cyclophosphamide, and dexamethasone, patients were randomized to receive or not autologous stem cell transplantation, but the patients allocated to the transplant group had the possibility to receive single or tandem autologous stem cell transplantation. tandem autologous stem cell transplantation was superior to single in terms of both PFS and overall survival. But I would like to remark here how tandem transplant was especially effective in patients with high-risk cytogenetic abnormalities. And when patients received tandem autologous stem cell transplantation, the progression-free survival for standard risk and high-risk patients was comparable. This is another study. This is a large meta-analysis conducted in approximately 1,000 newly diagnosed myeloma patients receiving bortezomib-based combinations as part of the induction regimes, and some patients received single, some patients received tandem autologous stem cell transplantation. But the results are similar to that previously reported by the European Myeloma Network study. Tandem autologous stem cell transplantation benefit to patients with ISS 2 and 3, but the patients who get the most benefit from tandem transplant were those with 414 translocation plus minus deletion 17p. At last ASCO meeting, we had also the opportunity to see an update of this STAMINA trial, in which after autologous stem cell transplantation, a large series of newly diagnosed myeloma patients randomized to receive no consolidation, consolidation with VRD, or consolidation with a second autologous stem cell transplantation. And in this update in ASCO 2020, tandem autologous stem cell transplantation was superior in terms of progression-free survival for patients receiving tandem autologous stem cell transplantation for patients with high-risk cytogenetic abnormalities. So definitely, I think that today tandem autologous stem cell transplantation is a standard of care for patients with high-risk cytogenetic abnormalities. With this background, in 2020, it is possible to challenge today the autologous stem cell transplantation? The answer is yes. This is a study conducted by the French group in which after induction with bortezomib, lenalidomide, and dexamethasone, patients were randomized to receive 5 additional cycles of bortezomib, lenalidomide, and dexamethasone or transplant. In terms of response rate, transplant was superior to only conventional chemotherapy, conventional bortezomib, lenalidomide, and dexamethasone, and this benefit translated in terms of progression-free survival, and transplant resulted in a median progression-free survival of 50 months versus 36 months for bortezomib, lenalidomide, and dexamethasone alone. However, this benefit in terms of progression-free survival did not translate yet in terms of overall survival. A second study conducted also by the European Myeloma Network did a similar comparison, transplant versus consolidation with bortezomib, melphalan, and prednisone after induction with Cy/Bor-D. And transplant was superior in terms of progression-free survival, but again, when overall survival was evaluated, no significant differences were observed. This is another study incorporating the second-generation proteasome inhibitors, carfilzomib. And carfilzomib was here combined with cyclophosphamide or lenalidomide and dexamethasone, followed by autologous stem cell transplantation and consolidation. But there was a third arm of patients in which no transplant was included, and this group of patients received carfilzomib, lenalidomide, and dexamethasone 12 cycles. When we did the comparison between KRD transplant KRD versus KRD 12 cycles without autologous stem cell transplantation, the VGPR rate or better, as well as the complete response rate or better, and even the minimal residual disease negativity rate was comparable for both groups. And this would put in context that maybe when we incorporated the second-generation proteasome inhibitor, transplant would not be necessary for all newly diagnosed myeloma patients. And in fact, the answer to the question about the challenging for autologous stem cell transplantation today would be the answer yes, but I would like to address if it is possible to avoid, again, autologous stem cell transplantation in every newly diagnosed myeloma patient. And we are going to see how the answer is no, and maybe we can potentially avoid autologous stem cell transplantation just in some patients. In this slide, you can see here again the French study in which transplant resulted superior to no transplant in terms of progression-free survival, but not in overall survival. But now here you can see represented the progression-free survival according to the minimal residual disease negativity rate. And overall, in the intent to treat patient population, when patients achieved MRD negative, the outcome was significantly better. And what is much more relevant is the outcome in progression-free survival for patients achieving MRD negative is independent of the treatment arm. And my question would be, is this information enough to reserve autologous stem cell transplantation at relapse when patients achieved minimal residual disease negative? And here you can see 3 key points that I am going to address in order to select the potential subgroup of patients in which we can potentially avoid autologous stem cell transplantation in the upfront setting. Minimal residual disease evaluation is something dynamic, and the real value is not anymore MRD negativity, but sustained minimal residual disease negative along the time. Risk assessment, including the cytogenetic abnormalities, are necessary to be included in the equation. And finally, as I previously said at the beginning of my presentation, minimal residual disease evaluation only inside of the bone marrow is not valid, and imaging techniques should complement the minimal residual disease evaluation. This is again the Forte study when carfilzomib was incorporated as part of the induction. To put in context how, if we consider just these results, we would say that KRD transplant and KRD is comparable to KRD 12 cycles, avoiding autologous stem cell transplantation. But when sustained minimal residual disease negativity was evaluated, we can see here, like in all evaluable patients, 90% of the patients receiving autologous stem cell transplantation sustained minimal residual disease negative at 1 year, whilst the patients, 78% of patients who did not receive a transplant sustained the minimal residual disease negative at 1 year. But when we evaluate this effect according to the RISS status, we can see how patients with RISS 1 resulted in a comparable 1-year persistent minimal residual disease negativity, approximately 90%, whilst the patients with RISS 2 or 3 definitely benefited most from autologous stem cell transplantation. In this group, the sustained MRD negativity rate was approximately 90%, whilst only 72% in patients with RISS 2 and 3 when they didn't receive autologous stem cell transplantation. And this is complementary with the early relapses rate, and in the overall population, we can see how early relapses occurred more frequently in patients who did not receive autologous stem cell transplantation, but this difference is applicable to patients with RISS 2 and 3, whilst the patients with RISS 1, the early relapse rate was comparable for both groups of patients. Considering the imaging assessment that I previously alluded you as an optimal tool to be incorporated in the management of newly diagnosed myeloma patients, I previously said how in the Cassiopeia study, PET-CT was incorporated, and we can see here again, like approximately 70% of the patients achieved MRD negative inside and outside of the bone marrow, and when we evaluate this feature, MRD negativity inside and outside of the bone marrow, the outcome in terms of progression-free survival was significantly better. If we consider all these results, I would say that maybe patients at RISS 1, if they achieve MRD negativity inside and outside of the bone marrow and they receive an optimal induction regime, maybe these patients can potentially skip autologous stem cell transplantation in the upfront setting. But definitely we have to take this sentence in consideration because we need phase 3 randomized trials confirming this situation, because this information is coming from phase 3 randomized trials, but in which the main objective has not specifically to evaluate this question. How we will proceed in the future for newly diagnosed myeloma patients transplant eligible? Maybe every newly diagnosed myeloma patient will receive VRD or maybe KRD plus the anti-CD38 monoclonal antibodies, followed by autologous stem cell transplantation, maybe tandem autologous stem cell transplantation for patients with high-risk cytogenetic abnormalities. If after transplant the MRD is negative, patients will directly go to maintenance. If the MRD is positive, patients can potentially receive a consolidation in order to upgrade the quality of the response, followed by maintenance. But definitely there will be another possibility to give continuous therapy with 8 or 9 induction cycles based on 3 drug-based combination plus the monoclonal antibody. And if the patient is RISS1 and the patient achieves MRD negative inside and outside of the bone marrow, maybe these patients can proceed directly to maintenance therapy and to reserve the transplant at the moment of the relapse. Finally, what about cell therapy for the management of this population of a newly diagnosed myeloma patient? You know maybe that BCMA has been the most common target for cell therapy in multiple myeloma, and definitely the BCMA targeted therapy or the cell therapy in general in myeloma has been evaluated so far at late advanced stage of the disease. When we evaluate the progression-free survival after CAR T cells or bispecific monoclonal antibodies in myeloma, definitely these options of therapy cover an unmet medical need in myeloma, but they don't represent yet a curative option, as we have had the opportunity to see in other hematological diseases. However, all this cell therapy is rapidly evolving, and it represents or it covers an unmet medical need at late advanced stage of the disease, and cell therapy is being investigated right now in early relapses as well as in the newly diagnosed myeloma patients at high risk, also as consolidation after autologous stem cell transplantation, and in the future maybe cell therapy, today targeting BCMA, in the future targeting different targets, can potentially replace autologous stem cell transplantation. But this information is not mature yet, and we don't have any consolidated result at this moment. In conclusion, I would say that autologous stem cell transplantation remains today as the standard of care for young and newly diagnosed myeloma patients. Transplant is a complementary strategy after induction with novel agents-based combinations, and the quality of the response is upgraded. Tandem transplant is a recommended procedure, especially for patients with high-risk cytogenetic abnormalities. The absence of a benefit in overall survival in the 2 large phase 3 randomized trials makes possible to consider the patient's preferences, and I personally consider that a minimal residual disease together with the risk assessment evaluation will be included in the treatment algorithm and might drive the autologous stem cell transplantation choice in the future. Definitely cell therapy is coming, and we'll see how cell therapy is incorporated into the treatment landscape of patients with multiple myeloma. And finally, I would like to thank to the Spanish myeloma group, to all investigators, including patients in our studies, most of all thanks to the patients and the families, and also I would like to thank to the hematology department at the University Hospital of Salamanca for their continuous support for continuing investigating in multiple myeloma. And thanks for your attention. Thank you very much for the invitation to the keynote lecture.